So our next presenter is Dr. Abbie Leino from the Faculty of Medicine, University of Michigan in the United States. Abbie is a PhD candidate in the Clinical Pharmacy Translational Science program at the University of Michigan. Prior to her PhD, she completed her PharmD residency training and a clinical research fellowship in solid organ transplantation. Her research interests include identifying strategies to optimize immunosuppression regimens through the application of innovative therapeutic drug monitoring, clinical PK/PD modeling, and interventions to incorporate patients' preferences and behaviors to design more effective dosing regimens with fewer adverse events.
All right, awesome. Well, thank you so much for inviting me to join you this, I guess, morning over there is evening over here. And so I'm going to chat a little bit about my dissertation work this evening that's focused in kidney transplantation, but I really think a lot of it can be translated to infectious disease or whatever therapeutic area you're interested in. So hopefully, even if you're not a lover of transplant like me, you can get something from this talk. But for those of you that aren't as familiar with transplantation, our drugs come with a lot of benefits. Transplantation is an amazing and life-saving procedure. But if we don't dose our drugs correctly, we're at risk of having immune damage to those organs if we don't give high enough doses. But if we give too high of doses, our drugs cause a lot of side effects that also can contribute to our morbidity and mortality in these patients. And so we do routine therapeutic drug monitoring in our patients. We typically are just checking, at least here in the United States, tacrolimus, which is one of the drugs, and we look at just the trough concentrations. And we target levels based on population level data. So for some patients, it's great, and for others, it's not so great. But one of the things I think you can really see if you look at those concentration time plots is even for patients that have the exact same trough concentrations, they have very different total drug exposures, particularly related to, if they have a high peak or are not someone who has such a high peak. And so we can potentially do a better job dosing these drugs if we obtained more samples and estimated AUCs. However, this doesn't work very well in clinical practice. Patients don't want to sit in the clinic for several hours getting repeated blood samplings taken. The phlebotomists don't want to take repeated samples because they have other patients who are waiting. And so one of the potential benefits, as we've already heard, is these volumetric samples. And so this is something that patients could potentially do at home. The volumetric devices are particularly nice, as we've already covered. And so that's what I'm going to talk about today, is comparing two of the volumetric devices, the Metra device, which is from a finger prick, and the Tasso device, which samples through a lancet that attaches and punctures the upper arm. And so I am a pharmacist by primary training, and I learned a lot about analytical methods. But I'm not going to spend too much time talking about it this evening. But I will say this is a huge undertaking, as I think some of the other speakers are going to talk about this evening. And one of the key things is really the extraction. And if you don't get high extraction, good recoveries, you're probably not going to have good results down the line. And so this took us way longer than we thought. I think one of the key things I want to drive home again is that just because somebody did it with the Metra device doesn't mean it's going to work for the Tasso. So there are multiple methods for both our tacrolimus and mycophenolate from the Metra device, but none of them I could get to replicate in our lab with the Tasso. And so we had to come up with something entirely new. And so we use this impact-based or homogenization extraction. It allows us to have a really fast method that has really high and reproducible recoveries. So if you're stuck, that's what saved us here. I'll talk a little bit about clinical validation or the bridging studies. And so basically what this is just comparing the standard of care, gold standard, concentrations obtained from blood with these capillary stick samples. And as you can see here, for both of the devices, we had really nice results for the tacrolimus. There would be considered interchangeable based on the bioanalytical guidances that are out there. But when we look at mycophenolic acid, you can see not so much, right? Our line of identity isn't really where our regression line is for our passing blood block regression. And you can see that there is some bias there in the Bland-Altman plots, with the concentration in our VAMs or dried blood spot samples being lower than they are in serum. And if you have thought about this at all, you would know that this is not entirely unexpected. This is pretty much exactly what we would expect to see. Because when you think about the difference between whole blood and serum, essentially mycophenolate is not bound to the red blood cells like tacrolimus is. And so when you take the resulting smaller volume of serum or plasma, you'll obviously have a higher concentration. But we want to be able to think of these VAM samples from a plasma or serum perspective, because that's what the currently available therapeutic range is based on. And so we were anticipating needing to do a correction factor. And there's multiple different ways this can be done as reported in the literature. One is basically using that regression line, or coming up with this like a standard ratio type correction factor. And the other is to base it on the individual hematocrit of the patient at that particular time. And there are a couple of methods that have been reported for measuring hematocrit based on potassium, or estimating hematocrit based on potassium concentrations in the VAM samples, but I wouldn't consider that mainstream yet. And so what we said we're probably going to do is a ratio correction. And what you see here are the two previous studies that have tried to do that. They used about a 30% correction. And so applying the 30% correction to our samples, it looks a little bit better, but we still wouldn't be considered able to evaluate our samples using the current therapeutic range in serum or plasma. To me, 30% didn't make a whole lot of sense. So we've also looked at 40%, which is more of the average hematocrit of the patient population. And you can see that makes it a little bit better. And so we're starting to see results that we could potentially interpret using our existing therapeutic range. And so we're continuing to collect samples so that we have enough to actually validate an improved correction factor. And we have the hematocrits. Our lab isn't able to calculate the hematocrit from the VAM sample at this time, but we have the hematocrit from the corresponding or paired blood sample as well. So we'll evaluate that as well. And so these results look good, or they're heading in that direction, but they were collected by study staff, people who are well trained on the technique, and we know what we're doing when we get these samples. And so what might be different if we're going to send the patients home to collect these samples? And so thinking about what are our sources of pre-analytical error that might be introduced. And so here's a little snippet from the instruction guide for the Tasso device. You're supposed to stick it to your shoulder, activate the lancet, and start a timer for 5 minutes. But then if you look really closely in that small print, it says, keep your arm at the side and watch the dots fill with a mirror. You won't see blood right away. After 5 minutes or earlier, if the blood appears at the bottom of the pod, peel off the device. And so if patients miss that step, that it's 5 minutes or earlier, they can actually overfill the device. And so here's a picture of what that might look like. So you can see this is the kind of the back of the cartridge where in the empty, over here, this is an empty cartridge, and this is an overfill polymer that's designed to capture some of this extra blood. So every time you're not worried about overfilling. So if 100 microliters of blood is what we would hope patients would collect, which basically fills all 4 spots and makes it down to the bottom of the pad. 200 microliters fills more, but is not completely full. And then if you're looking at 500 microliters, which is possible to obtain that much blood from this device, because there's a little bit of a vacuum as well. You can see there's all this extra blood, and this can actually stick. So in these little circles here is where the tips would be, and extra blood will dry on there. And that will affect your, sorry about my animations got messed up there. So you look here at the bias that results in from these, the higher volume of blood, you can see a significant positive bias. And so if you were to receive a sample where you could see there was overfill of blood from these from a patient, you would need to discard it because it wouldn't provide you with accurate results. as you might expect. The other piece is to help with the vacuum pressure. There's this little clear plastic film that covers the sample cartridge that needs to be removed to allow it to vent and dry in a reasonable amount of time. If that is not removed, the samples don't dry. And so shown here is an experiment we did looking at the recovery at various dry times with the sample appropriately vented in the black versus an unvented sample where the film remains in place. And one of the interesting things that you can see is when you don't let it dry before you analyze the samples, we have like these outrageous recoveries. It happened every time we repeated this experiment, and others have found an issue with different drugs. It's been reported in the literature. So for whatever reason, if your samples are dry, you get crazy recoveries. But once the sample's dry, you can see in black that they're stable over the entire study period here. But at 72 hours, the samples that weren't vented are not dry. You can tell that they are not dry if you were to look at them visually, and you start to see a reduction in the recovery, which means that the sample is starting to no longer be stable because it's not dry. And these drugs aren't stable for prolonged periods of time at room temperature in wet blood, and we know that. So if they don't dry, again, you will have to consider discarding the sample that you receive. The first spot, you can see these large ranges. And so this up here is the first spot, which is closest to the top. That sample does seem to dry. So you may be able to kind of salvage the sample by only analyzing that first spot rather than some of the ones that are farther or deeper down in the pot. The other piece is to warm the blood, bring the blood up into the capillaries. You're supposed to rub the arm quickly and firmly. If that is not done or not done sufficiently, you won't fill all of the spots. And so you can see here that the first two spots are full. You can see a little bit of blood in the third spot, but obviously it's not full. The first two samples there were accurate and consistent with the whole blood sample, but obviously you wouldn't be able to use all 4 samples in that case. So while the device is nice that it collects multiple samples for you, you may not always get 4 samples, which may be a problem if your assay required the additional volume or something like that. So thinking about the mitra, as already mentioned, it can be hard and tricky to get multiple samples from one prick. Particularly if you're not using a large enough lancet. And so you really need to be using the blue lancet there that's 1.5 millimeters by 2 millimeters to get enough blood to fill 2 of the mitra tips. I started with the slightly smaller, not thinking it would make a difference, and I didn't fill tips most of the time, although patients found that lancet to be a lot less painful. So you definitely need that big lancet to get enough blood, or you'll end up with something like this where you have one of your tips full, but not the second. So thinking about transferring this to home, patient education is going to be really important. Focus on particular sources of error so that they can improve their technique in those spaces and hopefully increase the accuracy of your results. So things like the warming of the site of the collection, emphasizing, what we're trying to do and why we're monitoring this, and to look and to see, when does it reach the bottom, to actually use that mirror and not skip that step, and then remember to remove the film. So with education, patients can probably do this. It seems technically possible, but what do patients actually think? And as my bio said, I'm also interested in what patient-reported measures. And so there's kind of 2 categories: outcomes, which is more about like the level of pain or the quality of life that patients would experience, and then their experience, which is a little bit more all-encompassing, maybe something like, are they confident that they could do it? Do they find it easy to use and things like that? So I'm assessing multiple of these as well in this study. And so the first and kind of the obvious choice is to assess pain. And so we're using just a simple 0 to 10 kind of standard scale. And as you can see here, a lot of these patients don't find any of the sampling, whether it's the tassel from the arm, the mitra from the finger, or a standard venipuncture. Most patients don't really find any of these to be super painful. But you can see that, one patient of the vein rated at moderate pain compared to nobody from the capillary samples. Patients do tend to rate the Mitra higher than the Tasso, as far as they're more likely to say it's mild pain versus no pain for the Mitra device. And if you've ever had your finger poked, you can probably agree with that assessment as well. And so I also asked them to rank, kind of again, based on what we know about nerve distribution. You can kind of expect that the venipuncture of the finger would be more painful compared to the sampling from the upper arm in an adult. But since we've also been talking about pediatrics this evening, the Mitra or the Tasso device can also be placed on the lower back of a pediatric patient to collect samples there as well, which is also a less painful location. And so most patients rate it all equal. None of them cause any pain, about 36%. About 40% say the venipuncture is the most painful, and then varying degrees of whether Mitra or Tasso are different or the same. And then about 20% of patients say the Mitra is the most painful sampling technique. So then we ask patients, are you willing to obtain additional samples? So the whole point behind my work is to be able to estimate an AUC. And so there are more patients who are willing to collect kind of a full range, do a full PK study with the Tasso device, particularly in comparison to the vein, where most patients are like, yeah, no, please only take 1 or 2 samples from me every time you want to get blood. Whereas definitely more samples from the 2 capillary methods. When you ask patients to pick one, 100% pick the Tasso. I've had a couple people, most of these patients are getting samples collected on 2 days in a row. I've had a couple people on the first day say they preferred the finger, but by the second day, their finger's still sore where their arm is not. And so 100% prefer the Tasso by the end of their participation in the study. This also comes across in more of a qualitative perspective, so patient statements. A lot of patients consistently say that they prefer the arm. They'll say, oh, I didn't even feel it, you're done, you finished, that's it, that's all you want from me. That's easy. It definitely hurts less. And I think one of the statements that I've heard that most kind of represents why maybe we're not seeing bigger differences is that these are kidney transplant patients. So, and they're mostly new kidney transplant patients. So patients who are used to having large gauge needles to filter, their entire blood volume multiple times a week. And so this patient said, none of the poking and prodding bothers me anymore, but I did hardly feel the sample from the arm. And so even though poking these patients may not be the most painful thing to them, so we may not see these huge differences when we look at it specifically quantitatively, but it does come across that they have a preference for this sampling technique when you ask them and they describe their experience to you. We're also looking at usability. And so on this slide is a questionnaire called the System Usability Scale that's quite popular as far as assessing the usability of a whole bunch of different things that's been studied, an internet browser or your phone or, whatever. Is it easy to use or is it complicated to use? So it's a really nice scale. Most people find it to be very helpful to measure perceived usability. And so here it's on a scale from 0 to 100, but anything less than 50 is not considered usable. And it kind of rates from fair, good, excellent, best imaginable. And so when we're thinking about anything, an iPhone is like an 87. So a score of 100 is not really what we're expecting to see in this situation. And so if we look at a couple of common medical devices that maybe you're more familiar with, you can kind of get a feel for where we maybe would see this falling. And I like to look at the thermometer and say, I'm not sure there's anything easier to use than a thermometer, and its score is only an 82. So I'm not expecting that I'm going to do better than a thermometer. And in fact, I kind of anticipate I'd be somewhere around the glucose meter, since that's kind of a similar process, and that's exactly what we see. The Tasso device is a little bit more usable. Patients find it to be fewer steps because really all they have to do is press the button and it collects the sample themselves, rather than having to balance, a bleeding finger while they're trying to absorb, into the sponge on a stick. They do, again, report this in more of a qualitative perspective. They think that they can definitely do it at home. They're very confident that they could do it at home. They find it to be easy to do. I had one patient recently who said, it would be amazing if I could do it at home. It's pretty simple. You just slap it on your arm. So again, they continue to really report promising and satisfaction with this device. So then they also can recognize some of the potential benefits. And this is a research study, so obviously they've provided informed consent. But some of the things that they've recognized as potential benefits that I don't particularly talk about when we're going through the consent is, so there was a patient who I had to not allowed to participate the second day because their hemoglobin had fallen below the protocol requirements. And so I was stopping by to say, hey, I'm not going to get samples today. And they're like, so, okay, my blood count is low, but is that small volume of blood really going to make that big of a difference? And there's a couple of patients who have expressed a similar sentiment, as well as the flexibility with their blood draw time, right? So this is probably not going to change the amount of times these patients are going to have to go to a lab, at least not right now, because there's all sorts of things we measure in blood that we can't measure from the VAMs at this point in time, although there are some great studies looking at serum creatinine, which would certainly be helpful, but would mean maybe they can get their time sample and then for their tacrolimus trough and then go to the lab in the afternoon after work rather than having to get up early or something like that. All right, so patients like it, they think they can do it, it's usable. So what else do we need to think about to actually make this implementationable and actually accomplish doing this outside of a study? And so when we think about study outcomes, we usually think about the intervention or the patient outcomes, but it's also important to think about implementation outcomes. And what I'm assessing in this study is acceptability, feasibility, and appropriateness, because these are the three key predictors of adoption or uptake when you try to roll something out on a larger scale. And so these are exactly kind of what you would expect them to be. Acceptability is the perception that home-based therapeutic drug monitoring using these VAMS tools would be agreeable or satisfactory to the patient. As feasible means that they could actually successfully do it. And I'm not assessing appropriateness because my survey was starting to get a little bit long and I didn't want to add additional questions. So from a patient perspective, I decided acceptability and the feasibility would be the more important outcomes to measure. And as you can see, most patients agree or completely agree with the statements related to acceptability and feasibility. So patients would be accepting and thinking that could be something that they could do as part of their routine care. And so I think this is all very promising. And so what is the next step that we're taking? What other problems could we have? And so anytime you're dealing with patients, you have to think about adherence. So there are a couple of studies using traditional dried blood spots that look at sample collection and return longitudinally, and they have not great adherence. Only 45% of expected samples were received, and even fewer of those samples were received on time. So definitely we're going to need to do something to improve that. And then if we want to be collecting multiple samples for AUC estimation, we need to be thinking about residual error and estimating our PK parameters. And so there was a nice study that was done in the last couple of years, looking at one of the newer migraine drugs where they had dried blood spot sampling. And sometimes it was done in clinic under supervision, but the patient collected the samples, and sometimes it was done at home by the patient independently. And when they compared the residual error between the two models generated in those situations, the home collected samples had a lot more error than the clinic collected samples. And so since the both sets of samples were collected by the patient, it's probably not their sample collection technique. It's probably related to the documentation of the timing. And we all know that patient diaries aren't the most accurate. So in my next phase of the study, we're implementing a text message intervention. We're randomizing patients to either just get a reminder, so to hopefully just help with that adherence piece. If I remind you, you're supposed to do this, will you actually do it at a higher rate than 45%? And then the second group gets a series of messages that helps guide them through the sample collection at each time point, and they reply to the text message with the time that it was collected. So we have additional information, the time they write in their diary, the time they said in the text message, and the time the text message was actually received. So hopefully that'll provide us with some more accurate documentation. And so you can kind of see that here. We're having patients collect 4 samples to estimate AUC. We're also doing ecological momentary assessments, or EMA, to continue to capture data around how much it interrupts their day, what would they say the pain level is, would they be willing to collect a 5th sample, that sort of thing. And then when we're done, just because I think the qualitative data is so rich, we're going to do some semi-structured interviews to really dig in to learn more. And so I'm just about out of time. So definitely lots of people to thank for this work, in particular, the patients who are willing to participate in this with me. And with that, if I have time, I'm happy to take questions.
Wow, Abbie, that was fantastic. You have the best PhD. I'm sure you're having a great time doing it. Congratulations. Some fantastic work, and I'm glad that you're working with one of my very good friends, Amit Pai. And I note that you must also know Jason Pogue and Bruce Mueller from University of Michigan. So what a great place that you're working to do all of this work. So congratulations. I have one question for you, just because we've got a little bit of time. It relates to the frequency with which you would recommend TDM being done. Now, historically, it's done at a certain frequency which is related to feasibility of when people are coming into clinic, for example. But of course, with home-based TDM, if you're able to make this succeed, there is that possibility that people could have their monitoring done more frequently. It doesn't necessarily mean that they have to, but at the same stage, it means they could. So I'm just interested in what your views on that may be, whether or not you may change the frequency with how often TDM is performed.
So I think that is a fantastic question. In one of my studies during fellowship, patients actually collected samples daily using traditional dried blood spots as part of a big PK study, and we were using it as an adherence monitoring technique. But so they can do it daily. I don't want to analyze that many samples. That would be way too much work. But I definitely think there is room to be more flexible, particularly in a patient who we are seeing a lot of fluctuation in their levels. Every time they're checking it, it's coming back and we're changing the dose. I think there's lots of ways we could use this to explore why that's happening. Particularly tacrolimus is a very variable drug, and that's another area of my research, is looking at the sources of intra-patient variability. So from day to day, why are their levels so different? And so I don't know that I have a great answer to how often should we do that. I definitely think it's not studied. Like you said, it's convenience, or based on in kidney transplant patients, how often we want to check their serum creatinine, which also isn't based on very much literature. So I think we definitely need to think about that. The one thing I would worry about is clinicians seeing a whole lot of levels and making a lot of changes, not thinking about all of these sources of variability that are there. And so definitely I have a whole career worth of studies to conduct to help us understand what would be the best frequency, technique, documentation strategy, whatever to monitor.
I mean, I guess it just gives you the flexibility, doesn't it? And you can individualize the frequency with which you take the samples, I mean, from an occasion of TDM perspective, and your work will help facilitate that. So that's great. Thanks very much for your presentation.